Good afternoon. I'm Dr. Duke Majan at the Duke Spine Institute. We're streaming live spine surgery. Our patient comes from Miami, and he has neck pain, herniated disc, facet syndrome, radiculopathy, cervical brachial syndrome, and we've already treated his facets in the last surgery just a few minutes ago. Now we're going to focus on fixing 3 discs that are herniated, degenerated: C4-C5, C6-T1, C7-T1. I'm going to start by placing the needles into the discs. And once we have the needles in place, we're going to start with the bottom 2 discs, and then we'll finish up with the 4-5. Dr. B, you ready? Yes. So this is the left side of his neck. Remember, we already did his facets. That was the last surgery we did. Now we're going to go fix these 3 discs. Shot. 2, 3, 4, 5. I'm too low. I'm going to go a little bit higher. I'm going to place this needle and I'm going to leave it here and come back to it later. Shot. It's much easier to place the needle in the beginning of the surgery than at the end. He's got a very long neck. Everybody has the same number of bones in their neck and same number of discs. Everything okay, Dr. B? Shot. 2, 3, 4, 5. AP. We're getting a lateral x-ray and a front back x-ray to verify position of the needle relative to the disc. That's perfect. Go back to a lateral. Now, because he's got such a long neck, that's how he injured his C7-T1. Shot. 2, 3, 4, 5. All right, so shot. Perfect. AP. He should be supple. He's supple. He's supple enough for me right now. Shot. That's perfect. Right in the midline. So we're going to enter 4-5 and stay there with the needle. We're going to go down and fix 6-7 and C7-T1. We have 3 discs to fix. Shot. Shot. If you have questions, feel free to ask them. Henry will relay your question to me. 2,
yes,
3,
I will.
4, 5. I'm going to go a little bit deeper. Shot.
At this moment, no current questions.
All right. So let's go down and get those other 2 discs. He did not want fusion. That's all they could offer him in Miami. Shot. 2, 3, 4, 5, 6, 7. I think I might have to start at 6, 7 and go down to 7, 1. Shot. Shot. AP. Wait. Sorry, quick AP. Lateral. That's perfect. It's not often that we do C7-T1. It's extremely rare. 2, 3, 4, 5, 6, 7. Shot. All right, here we go. Shot. Shot. AP. Quick AP. That looks perfect. Lateral. I'm looking at the tip of the needle. I want to make sure it's in the midline. Shot. 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 Hitting like the top of the vertebral body. Shot. All right. It's a better lateral. Shot. I'm like sliding right on top of that end plate. There we go. Shot. The disc is extremely scarred in. Lots of inflammation. Shot. All right, we're in, which is the good news. Let's do our discogram. Num num.
Need any inline or anything?
I'm sorry, what?
You okay? You need inline? Okay.
No, we're okay right now. We're going to start with the top disc. Shot. This disc is extremely scarred up. I'm having a hard time injecting dye. And I could feel the scar tissue, by the way. I'm doing local anesthetic at both incision sites. I'm going to try one more time. Shot. Okay, I'm trying to inject dye, but it's amazing how much scar tissue there must be in this disc. That's unbelievable. You can see a little bit of, I think that's dye back there. What do you think, Jordan? Hard to say. It's the back of the disc. Shot. I'm going to try to pipe clean this, see if I can get any scar tissue out of the end, if that's what's blocking us. Shot. Come on, Jordan. Shot. Yeah. That's as pipe cleaned as I could get it. I could feel the scar tissue. So what is scar tissue from? It's from inflammation. This patient has obviously inflammation going on in the disc, specifically in the back of the disc. Unreal. No, I couldn't get any of this dye out. We see that from time to time. All right, I'm going to take my scalpel, make an incision. It's 4 millimeter incision in the skin. Feel free to ask questions. This is a 4 millimeter incision. Perfect.
Yes. We have a question
I'll take your question.
coming from Lanu
Shot.
on YouTube.
Taking out the needle, leaving the guide wire.
Lanu asking, are herniated discs and facets have the same pain? Just curious.
Herniated discs and facets do not have the same pain. Let's show our video on the 30 causes of neck pain while I gain access to the disc with my dilator.
Of course.
I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute. We're going to talk about the 30 causes of chronic neck pain. Chronic neck pain is neck pain that lasts longer than 6 weeks. There are 30 causes to chronic neck pain. The most common cause is the disc. There are 6 discs in the neck. These discs can become injured. The first disc is C2-3. Next is C3-4, C4-5, C5-6, C6-7, and C7-T1. The most common disc to be injured and cause neck pain is C5-6, followed by C6-7, followed by C4-5. The other discs rarely cause pain. Discogenic pain represents 85% of chronic neck pain. Next, the facet joints cause 10% of chronic neck pain. Facet joint pain is very common in patients with neck injuries and spine injuries. Facet joint pain is usually located on the sides of the spine, either right, left, or both. Facet joint pain gets worse with rotation of your head and neck, worse with extension. The most common facet joints to be injured are C5-6, C6-7, and C4-5. C7-T1 is another common facet joint to be injured. These joints, after injury to the capsule, will develop arthritis. It is the arthritis in and around the facet joint that causes the neck pain and stiffness with movement. Duke plasma rhizotomy is the best treatment in the world available for painful facet joints. Duke laser disc repair is the best treatment in the world available for painful discs. Other causes of chronic neck pain include fractures, tumors, infections, and muscle spasms. These other causes represent less than 1% of chronic neck pain. Thank you for joining us for 30 causes of chronic neck pain. Welcome back. You can see from our video, somebody asked, what's the difference between disc pain and facet pain? The answer is where the pain comes from. With disc pain, the pain comes from the back of the disc, called an annular tear, in the back of the disc in the wall, called the posterior annular tear. And when it comes to facet pain, the pain comes from a damaged facet joint. Both are in the neck, both cause neck pain, but the source is different. Fixing the disc pain will not fix the facet pain. Fixing the facet pain will not fix the disc pain. So you have to have the right source of pain. I think this is probably pretty good. Let me just take a look. We're at the back of the disc. Jordan, show us where the tip of the tube is. That's right. So let's go see what there is to see. Now, let's talk about disc pain, because the disc is the source of chronic neck pain. About 90% of patients that come to us, like this patient, let's go ahead and show the audience how does a disc cause pain and how do we fix it
Of course.
with laser surgery.
Disc injuries start with an annular tear. Damaged nucleus pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963. Disc injuries is a common cause of chronic neck pain. The inflamed annular tear causes neck pain. A 4mm skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes herniated disc fragments and debrides the posterior annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Welcome back. So now we've shown you the 30 different things that cause chronic neck pain, and more importantly, we've shown you the most common, which is the disc. You can see where in the back of this disc, you can see the crack down there. That is the space between the bones called vertebrae. That is the disc space. And what we're doing is we're using our laser here, which is about 0.5 millimeter wide, 0.5 millimeters, 0.5 millimeter. That's how wide that is. And I'm removing pieces of herniation, but what you can see is there's also some bone spurs here. That's this little ridge. I'm removing that as well. And you can actually see that everything is just completely iced in, just scarred in, so bad. This is one of the worst scarring of the disc I've ever seen. So this poor man has been suffering with pain for a long time, and clearly that pain is coming from the inflammation, which came from the tear in the back wall, and that's where the pain is coming from. But you can see the blue stuff is herniations, and I'm using my laser to break them down into smaller pieces, release them from their attachments, and what attaches the herniation is scar tissue. So scar tissue, remember, it comes from inflammation. So I'm releasing the herniations with the laser that are scarred to the bone spurs and the back of the disc. Any questions?
No current questions, so we do have a comment coming from an Andrew on YouTube.
Hi, Andrew.
Saying that they're going in for a C6-C7 fusion right now, and they're just waiting in the waiting in the OR, waiting for them to turn the OR.
Wow.
Excuse me. Yeah.
I'm amazed. You're watching our surgery from the pre-op area of your hospital? Where are you located? We wish you luck, by the way.
Of course.
All of us here at Duke Spine wish you luck. I hope your surgery goes perfect, and I hope you're happy and satisfied.
As we wait a comment on where they're from, we have a few more questions that just popped up. This next one coming from Lanu, once more on YouTube.
Hi, Lanu.
Asking, my grandma saw many surgeries at the hospital during the 1970s. The screen back then weren't as clear as they are today.
Yeah.
How do you keep up with today's technology that is evolving constantly?
That's a great question, Lanu. So technology, right, for audiovisual. basically, I stay appraised of all the new developments. This is my field. I have Luis as well to help me. We are always looking at new technology and assessing whether or not it's going to improve our surgery or our patient outcomes, patient care outcomes. So if there's something that comes out that's better, we're going to assess it and do it, try it out, and see if it is better. You know, either through analyzing the results that are published or talking to the surgeon or talking to the representative to gain more understanding of the procedure. And when it comes to audiovisual stuff, yes, we started with the best that you could buy at the time, and fortunately the best has done us well. We've evaluated the new system, and honestly the difference is, there's definitely a difference, but I don't know that it's better, that much better, to warrant purchasing it. We're talking hundreds of thousands of dollars. We just don't have that in our budget at this time. If money wasn't an issue, we would do it. I would buy it. But money is an issue. We're not a hospital system. We don't have unlimited funds. We only have the money our patients give us and the money we get from the insurance companies when they pay. And that's it. So we don't have endowments. We don't have donors. We have nothing except the money we get from the patients. And, you know, I believe when I'm buying things, I believe I'm spending their money. So I look at it as a responsibility to not buy things that are unnecessary, that are not going to help the patient get better. You understand? It's different if you have a research grant or an education grant and you can buy things for research and education because somebody's giving you the money to do that. But the patients aren't paying for research and education, they're paying for surgery. So it's not right for them to have to pay for things that they don't need, if that makes sense. So I don't feel it's appropriate to take more money from people to pay for things that they don't need. Basically, if the advancement will improve the quality of patient care, I'll buy it. If it doesn't, then right now I can't afford to buy it, so I'm not buying it. I don't know if that's a better way to answer it.
We have another question
Yep.
coming from Steve on YouTube,
Hi, Steve on YouTube. Welcome.
asking, I have neck pain and mild weakness into shoulder, intermittent tingling on the left side. Physician gave me a nerve test and it was okay. Is this possibly my disc?
Yes, it is most likely your disc. But you can find out for sure free with our virtual consultation that we offer. If you go to our website, dukespine.com, and Henry will put the link right there for you. But if you go to our free MRI review form, fill it out, and I will meet with you myself. I'm personally going to meet you, and I'm going to look at your MRI, and I'm going to do a brief examination of you through Zoom. And when I'm done, I'll tell you what's causing your symptoms. Okay? We do that all from the comfort of your own home. By the way, a lot of these are bone spurs here that I've been removing, and this patient has all these ridges are from chronic inflammation at the back of the disc from the herniation. The herniation caused all this to happen. If he didn't have a herniation, he wouldn't have any of this stuff. None of this would be here. He wouldn't have any symptoms either. So the herniation caused all this to happen. It caused all the scar tissue, all the bone spurs, all the destruction and pain that you're seeing here in the back of his disc. Now, once I remove this material here with the laser, his body will heal this area finally. After many, many years of trying to heal it, he's going to heal it, and it's going to feel better. The pain is going to go away. Somebody asked me earlier, Dr. Duke, how long does it take for the symptoms of disc pain to go away after your surgery? I said 90% of the time it's immediate. By the next day, our patients come in saying the pain is gone completely, I feel amazing, thank you. But in 10% of our patients, it takes longer. And that's people like this patient where there's so much damage done by the disease over the years that, I have to do an aggressive surgery, and that takes longer to heal from. You can just see, if you watch these surgeries often, you can see how much worse this is than some of the other surgeries that we do. It's a real struggle here. But I'm almost done with this disc, and then we're going to move down to C7-T1. Everything okay, Luis? Yeah. These are all pieces of herniation, by the way. I keep floating up, little pieces coming off.
We have a comment and or seeking advice from Pete on YouTube
Sure.
saying, I had moderate canal stenosis and had ACDF surgery. About 1.5 years later now, I have moderate to severe canal and foraminal stenosis on multiple levels in my C3, 4, 5, and 6. They now recommend posterior foraminotomy, but I am scared that I will have further issues after foraminotomy because I have had horrible results from the ACDF.
Yeah.
I don't know what to do.
Oh, I'm so sorry to hear that. Honestly, we can help you at Duke Spine. My best advice to you is this. Come to Duke Spine. Let us take care of you. We'll only do what's best for you. That's my commitment to patients. I only do what's best for my patient. I don't recommend anything else. A lot of these doctors are recommending treatments that are best for them. They are financially motivated, unfortunately, to recommend what is best for them. And at Duke Spine, I always put the patient's best first and foremost. And I will tell you what's causing your symptoms. I will answer your questions. And you don't even have to come to Duke Spine Institute. You just have to do a Zoom call with me, and it's free. You don't pay for it. It's free for anybody who wants it, okay? We do one free MRI review for everybody out there in the world, and it's done through Zoom. It takes 15 minutes. In 15 minutes, I'll do a physical exam that I can do over Zoom, and I will give you a diagnosis, what's causing your symptoms. I will also tell you the best treatment for it, and I will answer your questions. So for you, I don't know what your symptoms are. You've described your MRI findings, but you haven't told me what are your symptoms. So first thing I want to know is, what are your symptoms? Spinal stenosis is not a symptom. It's something you see on the MRI. It's a physical finding. Lots of people have spinal stenosis and no symptoms. So just because you have spinal stenosis doesn't mean you need treatment for it, okay? Most people have spinal stenosis and do not need any treatment because it's not causing any symptoms. Many people think spinal stenosis causes neck pain. It doesn't. Spinal stenosis can only cause two things, radiculopathy and myelopathy. Radiculopathy is nerve damage, which manifests as weakness in your arms, numbness in your arms, tingling in your arms. Or myelopathy, which is spinal cord dysfunction. These are all bone spurs, by the way, every one of them. And this is spinal stenosis over here, but it's pinching his nerves. I'm going in to relieve the pressure on the nerve. This is all just garbage, just sitting on top of his nerve, crushing it. This is spinal stenosis, by the way, right here. All this is causing the spinal stenosis you see on the MRI. The laser is very effective at getting rid of it without fusion. This is the future of spine surgery. You're watching it today at Duke Spine Institute. That's Dr. Berndez's little, what do you call it, slogan? All right. Yeah, so my advice is, let me see what's wrong with you and give you some advice, okay? It's all free. You do it through Zoom. Just go fill out the MRI review form, send us your images, and I'll tell you what's wrong. All right, we're just about done. There's really not a lot of herniation here. This is pretty much mostly scar tissue with old herniation. That's why I couldn't do the discogram. The disc was so scarred that it wouldn't accept dye. I'm going to put some antibiotic We don't want to have any problems with an infection. We've never had an infection in the neck or any laser surgery. Now we have had a reaction to the betadine, because sometimes if you use too strong of a betadine, you can get inflammation from that. And some people don't even know they're allergic to betadine, and we don't know they're allergic to it because they don't know they're allergic. And of course you can have an allergic in discitis. That's why we use a low dose of betadine. All right, let's bring the fluoro in. We're going to move from C6-7 down to C7-T1 if I can. 2, 3, 4, 5, 6, 7. Here we go. So we're done with number 6-7. We're going to migrate down one disc to, by the way, look how much blood we lost. We lost 1 drop of blood. Literally 1 drop. All right, shot. Any questions, type them up. In the meantime, I got to get my team to help me. I need a little bit of shoulder, a little inline, but not yet. Let's get the fluoro position first. Shot. All right, Jordan, let's align that 7-1 disc up perfectly. It's not bad. Just de-wag it. I'm pretty happy with that. So if you could center it just a little bit better, I think that's probably okay. What do you think, Jordan? Can we do any better? Are you wagged? Huh? Yeah. We're going to adjust the position of the fluoro relative to the patient. I don't know, man. I think that's too high up there. Can you bring that more centered, or are you going to get not enough penetration? Sean? Oh, that's good right there. I like that. Let's keep that. All right. So we're going to go for the disc below. We've already counted the disc, so I don't need a CC2 to count. I'm coming out with my tube, leaving my dilator in place. I'm going to take the dilator out now, and I'm going to move it. Shot? I'm going to move it south 1 disc. Here we go. Everybody ready? A little shoulder, a little inline. That's enough. I should be right at the edge of the disc. Shot. Yep, I'm right at the edge, just out. Let's get another shot. I want to make sure I'm in the middle. AP. Any questions, feel free to ask me, but right now we're doing another technique that I developed for the first time in the world, and that is sliding from one disc to another along the ALL, anterior longitudinal ligament. And shot. Perfect. A little bit off to the side. I need to go back to the midline. It looks like we're a little bit of scoliosis there, huh? Shot. All right, lateral. So I'm moving down to the C7-T1 disc. And again, normally you can't get this disc in most patients, but you can get it in a few. And he shouldn't have a herniation if this wasn't even like in a way to be herniated, basically injured, which is it is in his case. All right, let's see if I can get down there. Shot. I'm there. Now AP. Let's pray that we're in the middle. Shot. Perfect. Lateral. We're in the middle. So we're in the middle on the AP. We're right over the disc on the lateral. I just need to enter this disc right now. Shot. Uh-huh. And then I need to re-angle it. Shot. This is very hard to do, but we're getting it done. I say God willing. We're getting it done. All right, you want to do a little discogram? Let's do a little pipe cleaner. So we're about 4/5 of the way there, 80% of the way back. I want to see if I can do a discogram. Shot. That looks good. We're going to try a discogram. Any questions?
Yes, we have a
Sean?
question and a comment.
I felt the dye going. You see that?
Yes, we
The
do.
dye came out. So this disc is not as scarred as the last one. Shot. Now his collarbone is going to probably limit me a little bit, but we'll be all right. Uh-huh. definitely up against the back of the disc. All right, let's go ahead and put that in. Hold on, hold on. I'm fighting it right now. I'm fighting his collarbone. That's the problem when you're doing low discs. You can see the needle at 4-5 is bending a little bit, which is fine because we're pulling, working down here, pulling the tissues downwards. Shot? Give me a second. You see we're right above his collarbone there with this tube. All right, go ahead and put that on. I don't want to lose my dilator. Dilator's in the back of the disc. It's really quite good. I could be a millimeter back further. Let's just hold on to questions for a moment. Shot?
Copy that.
I need a focus right now. Shot? Little inline, inline. Guys, perfect. Little inline, you ready? Here we go. Shot? A little more. Here we go. Shot. I felt it move. We're good. A little more. Shot. Yes. Almost there. Team together. We got this, guys. Come on. Beautiful. I'm as far back as I can get. Shot. All right. We're there. We did it. This is not as far back as I want to be, but it's as far back as he's letting me be. Because he's got these bone spurs growing like this, blocking my progress with my tube. But we're as far back as we can, and it worked on the last disc. It should be fine. All right, we'll take the questions.
Question coming from Lanu, once more on YouTube, asking, do you accept financial donation? If yes, it has to be compliance with IRS, I think.
Yeah, we would take a donation, of course. I would only take a donation. I would take a donation as long as it's specified what it's to be used for so that everybody understands. For example, if somebody wanted to donate money for new equipment, they need to say it's for specifically for this equipment. I would talk to them. First of all, we got to see if we need it. If there's no need for it, there's no point in the donation. Or we would take a donation to help somebody out who can't afford the surgery. Those are my favorite because I want to be able to help people who can't afford the surgery get it done. And that's just, unfortunately, if their insurance won't cover it or they don't have insurance, which a lot of people don't have insurance or good insurance these days, I would love to be able to fix them. And I can't afford to pay for it myself, so that kind of a donation would be welcome. Donations for certain types of equipment would be welcome. I would love to take a donation. We could not afford to build our building in Orlando. It's too expensive. Costs of construction have gone up, and I could not afford that. I would love to take a donation for that building. I would even name the building after the person as long as they donate enough money. So yes, we would take donations as long as they're earmarked for things that we need that are directly related to patient care or education or even research. Research, I would love to be able to have a director of research to help me conduct clinical studies, review charts, collect data, do statistical analysis on outcomes, and get these data published so we can get more patients treated. Yes, so research, education, and maybe some equipment, and then patient care. Those are the kind of donations I would accept. As long as they're geared towards helping people get the care they need.
Next, we have a comment coming from Pete, once more on YouTube.
Hi, Pete. Welcome. I'm sure my staff would love a donation of pizza or lunch.
I would not mind that at all.
Huh? Right. All right. Sorry. Go ahead.
Pete said, my symptoms are a constant deep ache in my neck, fatigued all the time, and struggle to do tasks for a long time and just need to lie down. Not much numbness. You are very kind, and I will book a Zoom with you. I am typing from Australia, and I just wanted to add that this condition really takes a toll on me mentally, and your words give me hope. Thank you.
Well, Pete, I'm so sorry you're suffering. So first of all, that's kind of what I thought. It was more pain, that's wearing you down mentally. So the good news is we can fix pain, number one. We can fix all neck pain. Number two, your neck pain is not coming from spinal stenosis. That is a 100% guarantee. So we don't need to fix your spinal stenosis to get rid of your neck pain, okay? We need to get rid of the neck pain by identifying the source of neck pain, which in your case, it's probably your facet joints or your disc. And if it's disc, we're doing this treatment. If it's facets, just go to the prior surgery we just broadcasted, and we do the Duke plasma rhizotomy. By the way, that's a bone spur right there. You guys see that? I literally just shaved it down with the laser.
Yes, we do.
Goodbye bone spur. And just behind it is some more herniation. So I had to get rid of it. I don't take all the bone spurs out that I see. I only take out the ones that need to come out to make the patient better. Okay? Most bone spurs cause 0 symptoms. So we leave those alone. Yeah, I'm happy, Pete, to do your MRI review, give you a diagnosis so you know what's wrong. You don't even have to come here to get treatment. It's not required for us to do your MRI review. All right.
And at this moment, no current questions.
Okay, great. So let's, since, Pete has pain and he's had maybe facet pain, we're going to show
Yes.
everybody what facet pain looks like and why people get facet pain.
Facet joint injury is a common cause of chronic neck pain. The inflamed facet capsule tear generates pain signals. The best treatment for facet joint pain is the Duke plasma rhizotomy. The inflamed facet joint pain nerves are destroyed. The advantages with the Duke plasma rhizotomy is that it's an outpatient procedure that takes 30 minutes to complete, very minimal bleeding and pain after the surgery with immediate recovery and return to work the next day, as well as a 99% success rate and permanent pain relief with a single treatment. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
All right, welcome back. We were just talking about the first surgery for today, the patient we did the fusion. He's already gone home, by the way. He left about 2 hours after the surgery was over. This is all herniation. Look at that herniation. Look at that thing. Now, I want you to notice how smooth it is, how white it is. That's and the gold part, that's the calcium. That's the calcification from scarring. That's from chronic inflammation. Okay, that's an old scarred up herniation. And this is C6-T1. That was sitting right in his foramen. Okay, right on the right side. And it's gone now. Got out with the laser. Almost done. So the first patient's already gone. He did great. He had almost 0 pain. We were talking about why did he have almost 0 pain. And obviously he's got the best anesthesiologist in the world and the best team, the operative team, making sure everything goes well. But he also, we didn't have to retract his muscles for as very long like we used to if we put screws and rods. So had we done the hardware, we would have been in surgery for another hour and a half, and that would have caused more muscle damage and more pain. So because the surgery was shorter, he had less muscle damage. He has less post-op pain. That's a fact, Jack. All right. This is the right foramen. Oh, do you guys see the herniation
Yes,
come out
we
of
do.
there? It's like, you found me, I'm coming out. So a lot of people think the laser only works by vaporization. It doesn't. The laser has a second thing it does, and this is something I rarely talk about, but it's significant. It jiggles. And how does it jiggle things? It uses a pressure wave, okay? A pressure wave. Every time the laser discharges a pulse of energy, it also creates what's called cavitation in the water down here that we're using to irrigate, okay? And that cavitation is a shock wave. That's really what it is, a shock wave. So I am creating shock waves down here, but not the kind of shock waves that can hurt the patient, good shock waves that dislodge herniation and make it come out easier. That's why it came out. So it's actually the laser that does that. So the laser is not just a vaporizer, it's also a DJ, disc jockey. It makes the herniations dance. We want dancing herniations. Right, Luis? It makes them do the rumba, the samba. Huh? What else? Oh, yeah, the cha-cha right there. So we got the rumba, the samba, the cha-cha. We got all kinds of dance moves. Oh, another one right there. See that? Beautiful. Come on out.
Yes, we do.
Just about done. I need another 30 seconds on this disc, and we're going to our final disc. That's the L4-5, the upper one. Any questions?
No current questions, so we just have a few comments just praising your the job you're doing with.
This is all scar tissue right here. You guys see that? Like a
Yes,
wall
we do.
of scar tissue. Why am I cutting it? Because underneath it, it may be a herniation, right? And I want to release that herniation. I don't want to keep it there. So I've got to look. In that case, I didn't see one, but you have to look. If you leave this stuff here, you could be leaving a piece of herniation, and that will just cause more scar tissue. All right? Sorry, go ahead.
No current questions, so we do have just a few comments from Royal ViewTube and Kelly on YouTube. Royal ViewTube saying genius at work, and then Kelly saying expertise work, Dr. Duke.
Oh, thank you so much, guys. Appreciate it. It means a lot. I'm glad you're here learning. There it is. That's pretty much the end of this disc herniation right there. You guys can see the fibers of the posterior ligament. A little bit of herniation left there. I'm going to try to get as much of that as I can, and then we're done. There's a piece. Sometimes you got to cut these things in half to get them out because they're too big, these herniations. Look at that. What do you call that? The cha-cha? Luis? We need an interpretation, please. Or is that more of a samba? Samba?
We have a comment coming from Pete once more on YouTube saying, my neck herniations do a conga line dance from C7, C3 to C7.
I'm so sorry to hear that, man. Oh, look at that herniation that just came out. Do you guys see this thing?
Yes, we
It
do.
came out of the frame, and look at it, it's still coming. How many pieces is that? It's like a dragon. That is the conga
Oh,
line
wow.
that Pete's talking about. Right there. Look at all those pieces.
Yes, we do.
Wow. That they just I put a little pressure and they came right on out. You know, it reminds me of that movie, that show on TV when the police go to the house where the drug dealers are and they bang on the door and then people start running like cockroaches.
No, Live PD.
What is that called?
I think it's called Live PD.
Live PD.
Yeah.
All right, so it's like I just showed up with a laser, like the law. Hey, any herniations here? No. And then suddenly they're busting out trying to escape, right? Trying to get away. Like, oh, they caught us. Right, Luis? We're not going to let them get away. The only place they can go, by the way, is up the tube. So that's good. We only want them going up the tube and out. Oh man, all those there were like 5 or 6 of them connected there. And this is C7-T1. Here's a couple of them trying to get them out. But you're watching removal of herniations from the back of the disc where the herniations are causing problems. And people ask me, Dr. Duke, do you do a discectomy? I say, no, we're not taking the disc out here. We're doing I don't have any irrigation. What's going on? I have no irrigation. What are you guys doing over there? Oh boy. Thank you. Let's stay on top of that, please. No irrigation, no C. I can't see anything. All right. Well, I started talking about police raids and one of my nurses got nervous. At least she's laughing at my joke. Okay, we're just about done at this disc. I don't see anything left. It's looking pretty dang good. Just gonna poke around a little more just to make sure. You guys doing all right over there? Don't make me send Jordan over there. Yeah, the irrigation is not great. Whatever you guys are doing, it's kind of weak. So let's work on it, okay? I can't really tell yet. I need another minute. I think it's better. I think it's better. All right, any other questions?
Yes, we have a question coming from Royal ViewTube once more on YouTube.
Royal, yes, Royal ViewTube, welcome.
Asking, Doc, what kind of symptoms this patient was feeling?
This patient primarily had neck pain, right? Nikki? Look at that bone spur. Nikki, neck pain? How many years? 7? How many years? 34. Oh, there you go. Neck and shoulder pain. And some occipital headaches. 34 years, folks. We're done. 34 years. I got one more disc, Dr. B. We're done with the two bottom. 34 years of neck pain, going from his neck down into his shoulder. We call that shoulder stuff cervical brachial pain, CBP. Very common. Almost every single person with neck pain has cervical brachial pain. And then cervicogenic headache is when the headache goes from your neck up to the back of your head, I think intermittently. And then some radicular symptoms as well on the right side. Done with 2, 1 more to go. And our next patient after this one, I'm going to show you. We're taking this tube out, hopefully, and I'm going to show you the incision. It's literally 4 millimeters, okay? I mean, if this surgery was done by any other surgeon, spine surgeon, orthopedic, neurosurgeon, the incision would be this big. It would be literally 3 inches, okay, big, from here to here. Ours is 4 millimeters. You guys see that?
Yes, we do.
Like you can't even see it. It's so small. I don't know. Can you see it?
Yeah, we can, but
Right
it is
here?
very small, yeah.
Like it's not even bleeding.
No?
The only thing
that's
that
incredible.
bleeds is where I stuck the needle in to do the medicine injection for numbing the skin. There it is. Right there. Okay? 2 incisions. He's going to get the Brevard vampire experience with 2 holes in his neck. Looks like he got bit by a vampire with, what is it when your teeth are really wide apart? Huh? Shut up. Gap.
Buck teeth?
Don't you think I could have thought of gap? We need like a dentist here. Like an oral maxillofacial surgeon. All right. Point is, 2 discs down, 1 more to go. Let's show them C2 and let's count for them. Look at the dye, by the way, in the retropharyngeal space. Show the dye in the retropharyngeal space. That's going around the esophagus. It leaked out from where we did the discogram injection, and now it's sitting there. Show the endotracheal tube That's the, nope, that's the esophagus. Yes, that's the endotracheal tube. It goes in the trachea. That's what they're giving them life support. And then there's the esophageal tube, braided temperature probe. You got a little clip over there for the EKG. Show them the EKG clip. And then you got the spine. Show C2. Yes, C3, C4, C5. So we're doing C4-5 next. I've already injected local. I'm going to make my 4mm incision with an 11 blade. We're going to finish this surgery, fix the last of 3 discs. No metal, no fusion, no hospital. This is outpatient. This is the future of spine surgery, folks. You're watching it here. All right, 2 drops of blood, the whole surgery. You're watching it at Duke Spine. The rest of the world is yet to catch up. And unfortunately, the more I look at why do these doctors not adopt new technology like this, the more I realize the reasons why are reasons that are very difficult to fix. And I don't, that's why when you ask me how far behind is everybody else in this technology, it's at least 20 years. And if I got a call right now from like Harvard, I could probably get them up and running in 5 years if they're motivated and they're willing to throw $100 million at it. They could have a program in 5 years where I teach the residents and the attendings how to do the surgery, and they abandon fusions. They will become the center where everybody wants to go. The other option is, you know, people that are kicking, not wanting to change. Those people are going to take 50 years. They'll never do this surgery in their career. Seriously. Their whole career, 30 years will go by and they'll never learn this surgery. Look at, we're in the middle. It's perfect. We are in absolute perfect position. Jordan will show you where the tip of the dilator is. You could see it right there. Show them. You guys see the arrow? Show the spinous process. There's the spinous process. Those little weird, like, they look like a trowel. All right. You know what a trowel is? What is a trowel? A hoe. a garden hoe. I mean, a hoe. You guys are dirty. All right.
How's it spelled?
I don't know. H-O-E? So, all right. So the spinous process, we were right in the middle where we're going in. You can see the dilator going, thank you. You guys are embarrassing me. All right, I'm going to go in. Luis will pull the guide wire. We're going right in through the anterior annulus shot. Now, people say, aren't you damaging the disc right now? No, we're not. We're spreading the annular fibers. We're literally putting a pin like into your shirt. We're not damaging the shirt. I want to do a discogram. We're just spreading the cotton fibers so we can do the surgery and then we'll take it out later. Shot? All right, perfect. So this disc, unlike the other two, is not as old and scarred up, and I don't feel any scar tissue really. Shot? Maybe a little bit. Oh, look at the tear. Shot? Guys, look at this tear. The tear is skinny. Yep, right there, and then it leaks out. So this is a skinny tear. All right, so we're going to follow that tear with the dilator to the back. And right to the herniation. Shot. The herniation is right here. We're in the herniation right now. And that's as far back as I want to go with dilator. And now I'm going to, for those of you who've never seen this, I'm taking this little skinny metal tube. It goes over the dilator. And it's going to go right to the back of the disc. And that's where we do the surgery. Shot. You know, it's not the front of the disc that causes problems. It's not the side. It's not the middle. Shot. It's the back. And I discovered that 20 years ago when I started doing these surgeries, curing pain. I realized it was the back of the disc, the back wall, that was the problem. And I've been talking about it for 20 years now. I've even published in peer-reviewed journals and meetings, peer-reviewed manuscripts. So trying to get the word out so people know about it. But the most effective tool we've ever found for educating the public is this live stream right here that we're doing today. I have people that have been watching these live streams for years. And we've been doing these live streams for 10 years now at our center. 10 years. All right, we're done with this placement of the tube. You guys see the tube here? Okay,
Yes,
so
we
we
do.
lost literally 2 drops of blood the whole surgery. 2 drops. No bleeding. This patient will not take narcotics afterwards. No opioids necessary because we're not damaging the inside of his body like the other surgeons do. All the other surgeries, ACDF, artificial disc replacement, laminectomy, foraminotomy, you know, whatever they're doing to stick things in your body, they're harming your body. Therefore, it hurts. Therefore, ergo, you need pain medicine afterwards. These patients take a Tylenol, and that's it. Sometimes they'll take a muscle relaxer, one of them, before they go to bed, and that's all they take. And then they're out of pain the next day. So this really is the most advanced spine surgery in the world for disc problems. Okay, last disc, Dr. Berndes, we got 10 minutes. I let my anesthesiologist, this is already herniation. You can see the pink stuff. That's the inflammation.
Yes, we
I
can.
let my anesthesiologist know this because he's going to start waking the patient up. We want to coordinate our efforts so that this is all herniation, by the way, all this stuff. It's got some calcium right there. You see the gold? That gold stuff
we do.
is not gold. It's literally, that's what happens when the laser energy hits the calcium. It oxidizes it. And when the calcium gets oxidized, that's what it looks like. Okay? All right. Any questions?
Yes, we have a question coming from Pete once more on YouTube. Ask,
Pete?
yes,
All right. Bring Pete's question.
of course. If I had the treatment for facet joints due to degeneration, would the problems at the facet joints return, or do the results from the laser last long term?
Pete, great question. I'm glad you asked. The answer is our results at Duke Spine are permanent. You won't have to do them again. Okay? It's a permanent fix. However, anywhere else in the world, it's not permanent. So they're not doing the same thing we do. I pioneered a permanent version of fixing the facet pain. It's called the Duke Plasma Rhizotomy. We actually show you guys how we do it. We just did it on the video before this one, but you can go back and watch it. It's really quite simple, but I'm the first in the world to do it and the only one in the world that does it. So the difference is our treatment is permanent. It gives permanent pain relief to facet pain. And let's just run that facet joint animation one more time,
Copy that.
just for Pete's benefit.
Of course.
Pain, cervical facet pain, causing chronic neck pain for our new friend down in Australia.
Australia, correct.
Yeah, from the land down under.
Exactly.
Related, of course, to none other than Crocodile Dundee, I'm sure, right? Isn't everybody in Australia related to Crocodile Dundee?
That's what I was told, yes.
So, oh, look at all these herniations coming out. That's crazy, huh? So, it's important to keep in mind that the disc, which is what we're working on right now, is not the only cause of neck pain. There is other causes, but really the only other cause is the facets. And it's just a matter of figuring out which ones are bothering you. That's about it. Disc or facet in the neck. That's 99.9% of neck pain is either disc or facet. The key is which disc. And most surgeons cannot make the diagnosis. They have no clue how to figure out which disc is causing pain. They just don't. I figured it out over years and years of practice, trial and error, and now we know how to figure it out reliably. This patient comes from Miami. We're just about done. I got 3 minutes left on this disc, but you can see he had 3 herniated discs causing his neck pain. One of them was super old, super degenerated, probably been around for about 35 years, causing symptoms. The other ones, this one is more recent. This is about, if I had to guess, I'd say 5 or 6 years old, this injury. And then he had the other disc that we just fixed too, number C7-T1, which I would say was probably somewhere around 15 years old. So each of these discs, age of herniation and degeneration is different. Some are older, some are newer, and the original injury of the annular tear probably happened at the same time, but the herniations happened obviously different times, as evidenced by the inflammation. All right, last piece of herniation right here. I'm floating it up and out. Okay? Up and out. All scar tissue here. All scar tissue. That's what all this stuff is. But I don't see any more herniations. It looks great. I think we're done. Just going to take one last peek towards Luis, this right side. 30 seconds. Any other questions?
At this moment, no current questions.
All right, I do want to say one last thing. We have a new member of our Duke Spine team. His name is Brandon. I want to introduce everybody to Brandon. Is he still there?
Yes, he's right next to me.
Brandon is training to basically learn the audiovisual system, broadcasting, so that Henry can actually go on vacation one of these days and not worry about whether or not you guys are able to have a great experience in his absence. So, want to welcome Brandon to our team.
Of course.
With a round of applause.
Thank you so much, everybody. Pleasure to be here.
All right, we're done here. Any other questions, feel free to ask. Otherwise, we're going to patch up this vampire victim. No other questions?
No current questions, sir.
Surgery went very well for him. We got the front back, disc, and facet treatment. I think he's going to be very happy once he's healed up. He had a lot of surgery today. Thank you, Luis. Good job. Thank you, team. All right, second incision. We'll take a look at it in just a second. Whoop. Good. All right. Can you guys see this, Henry?
Yes, we can.
There it is,
Perfect.
the double whammy. So I want to know whose vampire teeth are 4 centimeters apart. Who's guilty? Who's the guilty one? This is where you really could use like teeth, you know, dental records to figure it out. All right. Thanks for joining us. Duke Spine will be back. Our next patient, she is not going to be broadcast because we're going in room 2. We don't have a camera. So we'll be back for our last surgery, which is a lumbar Duke laser disc repair for back pain. That'll be about an hour.